بسم الله الرحمن الرحيم. في هذه المائدة المستديرة سنتحدث عن النظام الغذائي وسلوكيات تناول الطعام الحالة الحالية. ولقد ثبت من خلال المحاضرات التي حضرناها هذا الصباح أهمية وخطورة الطريقة الغذائية غير الصحية وغير السليمة في تطور نسب هذه الأمراض في العالم أجمع وفي المجتمعات العربية، مما يقتضي أن نركز عليه في هذه المائدة المستديرة من حيث نوعية الأطعمة وكذلك سلوكيات تناول الغذاء. ولكي نربح القليل من الوقت بحكم أنه لم يبقى لنا الكثير، سيتكفل السيد فرانشيسكو برانكا وهو مدير التغذية من أجل الصحة والتنمية في المنظمة العالمية للصحة بجنيف، سيتولى مهمة تنشيط هذه المائدة المستديرة. فليتفضل.
Good afternoon, everybody, and thank you very much, Your Excellency. I would like to thank the organizers for having created this important opportunity of discussion. And I would like maybe to, if the Minister allows me to allow people to introduce. Okay, so we'll ask maybe the panelists to briefly introduce themselves. Then I will introduce the session with a few slides, and then we'll move to the panel discussion. So maybe can we start from my left? Can you introduce yourself, please?
Okay. Hi, everybody. Dr. Saad Khalil, Ministry of Agriculture, Organic Project in Saudi Arabia.
I'm Dr. Ayub Jawalde, Regional Advisor in WHO EMRO.
Abdurrahman Musaiqar, Director of the Nutrition Center, Arab Center in Bahrain, and Professor of Nutrition, University of Bahrain.
عايض القحطاني المشرف على كرسي السمنة جامعة الملك سعود. دكتور القحطاني Director of Obesity Chair at King Saud University.
Ida Rohana, Preventive Medicine Advisor in Saudi Aramco Preventive Medicine Services Division.
I'm Graham McGregor, Professor of Cardiovascular Medicine and Chair of World Action on Salt and Health.
Thank you very much. So you've heard today, this morning, already an introduction by Professor James of the importance of dietary factors to improve non-communicable diseases. I would like to maybe set the scenes by reminding everybody about the dietary risk in the Eastern Mediterranean region. We heard about obesity and overweight, sometimes exceeding 60%. We heard about high prevalence of diabetes. And the characteristic is that there has been a dietary transition, you'll hear more from Dr. Al-Jawalde, with increasing intakes of total fats and saturated fatty acids, an increasing sales of manufactured food and soft drinks, a low intake of fruit and vegetable in more than half of the population in most member states. We don't know a lot about sodium intakes and trans fatty acids, but we expect this also to be an issue in the region. And we heard about poor exclusive breastfeeding rates under 6 months and early introduction of complementary foods. This is the situation and the trends of fat intake, and you see the Eastern Mediterranean region has high levels. It comes third after the American region and the European region, comparable to the Western Pacific region. Saturated fatty acids are also on average about 10%. But you see in the right side of the panel, the the red line is the Eastern Mediterranean region with very quickly increasing intakes of fat. And this is the sales of food and beverage commodities, particularly the high in salt, sugar, and fats. And you see that in high-income countries, soft drinks and packaged foods are leveling off, whereas in low and middle-income countries, including many countries of this region, they are quickly increasing. So this is really an emerging market, as also was pointed out by Professor James this morning. WHO has introduced this concept of best buys. These are cost-effective interventions that are cheap, feasible, and culturally acceptable. At the same time, for diet, we're still looking at a broader set of interventions. Some of them still need to be costed, and they may perhaps generate less health gain than the best buys, but still are something that member states should be considering. So you see, this is the list of the best buys that you have in the WHO report: the reduction of salt intakes, the replacement of trans fatty acid with polyunsaturated fat, the promotion of public awareness about diet, but we also have there, as interventions to consider, the restriction of marketing of food and beverages to children, the replacement of saturated fat with unsaturated fat, the establishment of food taxation and subsidy system to facilitate healthy choices, counseling in primary health care, the provision of education in work sites and in schools. And you see the yellow ones are also low-cost interventions that have shown effectiveness, so they could well be considered. You'll hear more by Professor McGregor on how to restrict salt. It is a mix of actions. It is a mix of orienting the consumers by salt awareness campaigns, and a dialogue with the manufacturers and the distributors of food, with an establishment of food targets to progressively reduce salt in food. This has to go hand in hand with labeling regulations and good monitoring and surveillance of intakes and sources of sodium. I'll say a bit more about trans fatty acids. What are trans fatty acids in food in the region, and how to replace them with polyunsaturated fatty acid? The first step is certainly to make clear that trans fatty acids are associated with poor health, and to raise this awareness among policymakers and the population. Then you have different options. There are voluntary reformulation and mandatory regulation of food standards. And at the same time, the labeling that could also be either voluntary or mandatory. But we have some good successful examples. These are examples from Europe and North America. In Denmark, there has been mandatory compositional restriction of trans fatty acid in fats and oils to less than 2% of total fatty acids. And this approach seems to be very effective, and in a few years there has been almost an elimination of trans fatty acid from the food supply. In Canada, there's been a mixture of voluntary and mandatory. Labeling is mandatory, and reformulation is voluntary. But what the Canadians did was they convened a multi-stakeholder group in 2006 that agreed that the vegetable oils and soft spreadable margarine sold to consumers should contain less than 2% of total fat, and then that also the trans fat content in prepared foods should be limited by regulation to 5% of total fat content. And there has been some progress reported already in 2007 in the food content. Perhaps the most successful example has just been documented in New York. In New York, there was a regulation, there is a regulation that restricts using, storing, or serving food that contains partially hydrogenated vegetable oils. And you see the left part of the slide. It started with awareness. It started with education campaigns. Then it went to voluntary, and then eventually phase 1 and phase 2 is then where you have the regulation. And you can clearly see that the establishment of a clear regulation has brought down the content of trans fatty acid. And on the right, you can see the mean trans fat context before and after, and you see really a dramatic reduction of trans fats in food served in public outlets. And you can now have French fries with less than half the fat than before. The other intervention is saturated fat, and how to do that. Again, it's a combination of communication to the population through food-based dietary guidelines, and then a reduction of content in certain foods which are high in saturated fatty acid, particularly milk and dairy and some meats, but also prepared meals. Another very effective intervention is the replacement of cooking oils with varieties that have less saturated fatty acid and more mono and polyunsaturated. And labeling is always very important to inform the consumers. Examples here are the Polish example and the abolishment of government subsidies to butter and lard production in the 90s brought very quickly into a 7% reduction of saturated fatty acid. Again, a good example from Finland, and skim milk was consumed much more than whole milk. Low-fat margarines based on canola oil and low-fat cheeses were introduced, and there was a reduction in about 35 years of 9% saturated fatty acid from a very high level of 22 to 13%. Iceland also had this similar reduction from 40 to 36%. And this is a very clear example from Mauritius. There was a decree to basically replace the use of fat for cooking from palm oil mainly to mainly soybean oil, and you could see that the change in fatty acids was remarkable with less than 23%, with more than 23% reduction of saturated fat and 13% monounsaturated. But this is interesting with a replacement, total replacement by polyunsaturated fatty acids, which increased by 36 grams. The next important intervention is the control of marketing foods and beverages to children. The World Health Assembly has approved a resolution in 2010 to basically guide efforts by member states in designing or strengthening existing policies on food marketing. The set of recommendations explain what policy development implementation could take place and give some suggestions on how to do monitoring and evaluation. And basically, what is required by member states is to identify the most suitable policy approach given the national circumstances, and have a good system of monitoring and evaluating, and establish an intergovernmental collaboration to reduce the impact of cross-border marketing. So any agreement at regional level would be extremely important to achieve this goal. We have, again, some successful examples on marketing food to children. In Quebec, in the 1980s, there was a full ban on advertising to children, and there was a 7 to 9% drop in the probability of purchasing fast food. So that means 11 to 22 million fast food meals less that are consumed in that country. In France, in 2004, there was a food advertising regulations that led to change in dietary habits of adults and also food purchasing habits of adult individuals. In the UK, a recent ban on advertising to children has led to young children 4 to 9 seeing 52% less advertisement on unhealthy food. And I'd like to maybe close by saying that there are also economic tools that could be considered as a supplement, as a complement to these other regulations and measures. And Western Pacific is actually leading on taxation on beverages, taxation on foods that have been seen in American Samoa, Fiji, Solomon Islands, which sometimes is also linked to the establishment of a prevention fund, like in French Polynesia, or as it has been done in Thailand for tobacco taxes. Very important has been the introduction of import laws that limited import in some of these islands of foods high in saturated fat. This example has been taken up by European countries, and Hungary has been leading. 2011, they started a taxation system of soft drinks based on sugar and fruit content. Energy drinks were also taxed, packed sweet biscuits, including chocolate and ice cream based on sugar content, crackers, condiments. And the taxation is actually different according to the product, but we still do not have any data, but certainly there is some experience in how to establish this system.